test 1, 2. Alright, this is our 15 lead EKG. Remember when 3 leads was enough, presented by Blake Riddell, paramedic with Andrew County Ambulance District. This is a training video for our staff at Andrew County Ambulance District. I'm recording this voiceover from a presentation that I've already kind of went through, so if I'm a little off, I'll try my best. Alright, the objectives for this class are to list situations when you want to run a 15 lead EKG, list conditions that you are looking for with a 15 lead EKG. You're going to tell how you would alter your patient care based on these findings, and describe the locations for the electrodes on a 15 lead EKG. Alright, so what I started this off with is lead 2 is the only lead you'll ever need to look at, is what I was told in paramedic school. We did all our rhythm strips, we did everything. We were told we never need any other reason. And you can see here by the little arrow thing is this is for lead 2, or the 3 lead monitor, then the 4 lead monitor, and then the 5 lead monitor. So just showing you that things progressed, went from 3 to 4 leads to 5 leads, and eventually we went all the way to, ta-da, 12 leads. Now, I've said this back before 2000, it doesn't matter where the heart attack is, you're going to treat it exactly the same, no matter what. I said this, was I right or wrong? Awkward pause. Obviously, I was wrong. Where the heart attack is does make a difference. Now, what I did do was in 2005, I was tasked with teaching everybody how to do 12 leads. I showed them the positive leads, the negative leads, the unipolar leads. I showed them the little wheel with the axis and the axis wheel and how to interpret that and some of the things that it meant, which is important. All this is important, but it's not as important as kind of what we're talking about today. Today we're trying to talk about a quick thing. Now, during this presentation, I talked a lot about all these different waveforms and all the things that a 12 lead can really tell you, and they can tell you a lot. But after 6 hours of this, that was the reaction of most of the students in my class. So I wanted to just try to do a very basic, very basic breakdown today. Now, what I did learn and what's very important is this is your 12 lead tracing. And where the heart attack is important, and we're basically going to be looking for the inferior aspect. And then we're also going to look a little bit at the V1, the septal, just the V1 though. So the 3 main boxes we're looking at are the inferior boxes there and the septal there. So what we're talking about here is what are we going to do when we see issues with those boxes? You have to know where the inferior leads are. Now, I call this a posterior quick guess. If you look in V1 and you see depression that is not normal, what you can actually do is flip the EKG over, and if you look down on the bottom section in the blue circle, there is elevation. What that's significant of is a potential posterior MI. So elevation upside down V1 or just depression in V1 is a posterior. So what you need to do is you need to put a 12 lead on or 15 lead to try to find out if that is confirmed or not. So you definitely want to do a 15. Now here's the case. 58-year-old female presents with weak and tired, no energy this morning, which is rare for her. She's almost so weak you have to assist her to the stretcher. You place her on a monitor and do a 12 lead before you pat her hand all the way to the hospital. You look and see no elevation on a 12 lead. You flip it over, check V1, and see the elevation went upside down. You do the 15 lead to confirm, bam, you're a freaking rock star. You call the STEMI, they catheter, it's a 90% stenosis and a 70% stenosis. So posterior is good when it's kind of unexplained issues going on. Look for the posterior. They might be having an MI even though the regular 12 lead shows nothing at all or just has that little bit of inversion depression in V1. So this is the reason to do for the posterior. And this is one reason we do a 15 lead is because of the posterior leads. A posterior MI. Now when we talk about the inferior MI, I want to stress that we only used lead 2 for a lot of years. We didn't have 12 leads. This is the inferior aspect. So anytime we saw elevation in lead 2, we were seeing an inferior MI every time. And we've been treating these heart attacks for years and years without really knowing what part of the heart it was located or caring. So we potentially had all these years of treating inferior MIs, which an inferior MI alone is not a problem. If it's just an inferior, it's fine. So, but we do, with a 12 lead, we do want you to know which lead are inferior and what to do when you see them. I want to stress, an inferior MI is not a reason to stop treating. If they are solely an inferior, it's fine. The problem is you want to make sure they don't have a right ventricular infarct. So an inferior is a red flag to do more investigation to make sure that you check for a right ventricular infarct. So the three reasons is an inferior MI, to confirm or suspect a posterior MI, and if you're bored and you want to make your paramedic student work. Again, inferior MI, still treatable, nitro, all the normal stuff. Now, 15 lead EKG, we're going to do a V4R, which is the fifth intercostal space midclavicular line, V8, V9, and I'm going to show you here in just a second. You run your 12 lead just as you normally do, but you need to mark the different leads immediately so they just don't get lost in the shuffle, especially if you're multiple. Now, if you look here, V4 is midclavicular line. The V4R is opposite of that. So all you do is you put a lead exactly where you would if it was a mirror image, and that's where you attach your V4 to. So you pull your V4 off and you move it over there. You could also do 5 and 6 on the other sides, just like you do, and that would be a more right-sided chest X or EKG, but not so important. Now on the posterior, you want to go right at the point of the mid of the scapula, where the scapular points for the fifth one, and the sixth one is going to be between that scapula and that spine. So you want to put those on, and then again you're going to run a 15 or 12 lead again. So you've already run regular one, that's your 12. Now you're going to do 3 additional leads for the posterior and the V4R. Now again, you have to mark it on the 15 lead. Here we go. V4 is marked V4R. That signifies it's a right side. V5 is now V8. V6 is now V9. And you'll see in this case, they have elevation in V8 and V9, which confirms a posterior MI. Now, we also have elevation in V4R. This is an RVI, or right ventricular infarct. This is your danger sign. If you do a 15 lead, they have elevation in that V4R. That is when you have a right ventricular infarct and you want to stop what you're doing and think about your next actions. Aspirin immediately, but before you give nitro, before you give other things, these are pretty well contraindicated or used cautiously according to the American Heart Association in a right ventricular infarct. So, now an inferior MI on a 12 lead, 50% have posterior or right ventricular involvement. Of those 50%, 30% are only really bad enough to cause problems if you do give nitro, hence why we did it for years. So right ventricular infarct is a preload problem. You use the V4R to look for the infarction. Clinical signs are JVD, dry lungs, and hypotension. Hypotension and JVD and dry lungs. So if you get to somebody and they're not hypotensive, chances are they're not really having this RVI, but you're still going to be able to confirm it on the monitor. Now, treatment changes. For posterior, you're going to treat that as just any other STEMI. It's just a STEMI that you didn't see elsewhere. Inferior, immediate 15 lead to rule out right ventricular infarct. This is going to be looked at on QA. That's why we're having this. We found some of these issues on QA. Treatment for the right ventricular infarct, aspirin. Make sure you have IV fluids running, not just a saline lock. And in contact medical control, nitrates and morphine are used with caution. Fentanyl might be a good alternative. Somebody with a blood pressure of 100/60 might not get nitro, even though it's within numbers. But yet somebody with a blood pressure of 180/80, they might still get nitro. So call medical control, tell them what you have, tell them where your situation is, and let them advise you on what they want to do. We're probably going to be taking pictures with cell phones, if we have anybody's cell phone, and transferring those right to the cardiologist. That's something that's coming down the line that Mosaic is doing right now. Buchanan County's working on doing it. So it's something we're going to be looking at doing maybe in the future for those that carry their cell phones and those that want to. So again, we're looking for the RVI is what we're looking for. That's the detective work that we're trying to be very careful and find. So in conclusion, you run your 12 lead quickly. You want to get them on that 12 lead pretty fast. Look for a STEMI. If you see a STEMI that's in the inferior, you need to check and go beyond. And basically go forth, be awesome patient advocates. Look for those right ventricular infarcts. If it's just an inferior, treat them just as you normally would. If it's the right ventricular infarct, that's the time to say whoa and let's call medical control and figure out what they want to do. I appreciate it. There's a small test afterwards. Thank you so much. If you have any questions, feel free to see me at any time. Thank you.